Mm-hmm.
So who can start? Who starts with A? For example, we can give each question 2 minutes maximum.
Okay, so nobody is standing with A. I assume silence means no. Huh? Type, what about 79%? 79%. 89%. 99%.
I agree with
I say
99. Reckon.
yes, 99%.
Oh,
Yes.
great. So I see that so many of you have chosen 99%. Okay, Awad, are we going to show the answer now or later? Later, huh? Next question. A 50-year-old asymptomatic male patient with history of diabetes type 2 asks you to have a cardiac CT for him, that asymptomatic male. You will do coronary calcium score only, coronary CT angio only, both A and B, neither A nor B. So this is a 50 asymptomatic male with a history of DM and asked to do cardiac CT. How much are you going to submit to his request? Coronary calcium score only, CT angio, A and B, or not A, not B?
A. I will go with A.
You will go with A. Somebody else has chosen A and B. So calcium score and CT.
I will go with B.
You will go with B. CT angio
We
only.
vote for
Sorry?
C. We do first. We will vote for C. We started with calcium score. Then after we
Great.
receive
Type.
the
Okay. So
coronary
I would
calcium score,
remember
we
this
go
one
to
in
C angio.
particular. There is a bit of divergence here. So you need to have effort in explaining this one later. So we will go to the third question. A 55-year-old obese male has a history of DM and hypertension, presented to emergency department with chest pain. Contrast enhanced CT angiogram demonstrated the following. And here is the image. Two images actually. Okay. And the question is, what is your diagnosis? Severe proximal LAD disease lesion due to calcified plaque, moderate proximal LAD due to non-calcified plaque, severe proximal LAD due to non-calcified plaque, or moderate proximal LAD due to calcified plaque. So we need you here to tell us what artery and how severe and whether it's calcified or non-calcified. So which one you are going to choose by seeing these images. Again, back to the images. This is the artery and this is the lesion. So which artery, how severe, and whether or not it's calcified. So which one you are going to choose here?
This is severe proximal LAD lesion due to calcified plaque.
Okay,
I'll go
so C, severe proximal LAD due to non-calcified plaque. Any other options?
A. Severe calcified
A.
proximal calcified plaque. Yes.
Proximal due to calcified plaque. Okay. Any different opinions? Okay. So let's move on. Question 4. That's what you have. Okay. You have CT in contrast CT in two orientation, as you see in here. Okay. And it depicts a major abnormality. And we are asking you, the image shows an aortic intramural hematoma or penetrating ulcer, aortic dissection type A or type B. Back to the images. So, what do you think?
I will go with C. Type A.
You will go with C. Aortic dissection type A. Any other opinions? C. Okay, and C. So the majority with C. Great. A 50-year-old obese female, I think this is the last one, had a history of hypertension, presented to emergency department with chest pain. Contrast enhanced CT demonstrated the following. This is the CT. Okay, and two images side by side to tell you something. Okay, the question is, again, a female presented with chest pain, and this is her CT. I guess you know enough about the CT data. So we go to the question. Based on these findings, the most appropriate treatment for this patient is PTCA to LAD, lytic therapy, cabbage, reassurance.
Lytic therapy.
Lytic therapy.
Yes.
Anybody agrees or disagrees?
Thrombolytic therapy.
Lytic
Yes.
therapy. Lytic therapy. Lytic therapy. Okay, the majority lytic therapy. What?
Thank you,
Screen is
Hadi,
yours now. Thank you.
moderating this pre-test question. May you let me be the host, please?
You can share the screen now.
Okay. How to share the screen, Hadim?
طيب دقيقة. Okay, I make you a host now. Try again, share screen.
Now my screen appearing or not yet?
No.
No.
Okay. Is it appearing now?
Yeah.
Yes, exactly. خلاص عوض, because you are now the host. I think the recording had stopped or something. So
So
go
you want
for
me to
recording,
record?
huh?
Okay, let me record. Huh?
Okay.
Let me try to record, please. It appears with me that recording is active. The option only pause
Okay.
recording or
خلاص.
stop recording.
لا لا
I
خلاص
think-
خلاص. Keep it.
Okay.
It's active meaning. Yeah. Okay.
Okay.
You can start
So,
now.
Assalamu
Go ahead.
alaikum all. It is my pleasure to present to you a lecture about basic concepts about cardiac CT for the cardiology fellows. I try to put the format of the lecture in form of basic informations about cardiac CT, and also in some part I make it some interactive, so we can share knowledge between presenter and participants and attendees. So I hope to enjoy, and I hope to present you something which can help you in your board and in your future life as a cardiologist. So to start with, usually one of our main problems is chest pain evaluation, either in ER, in inpatient services, or in outpatient services. So evaluation of the chest pain syndrome in cardiology is most common clinical problem and scenario. This because you have many options or many directions to go, whether to go for CT angio, for nuclear stress test, SPECT or PET, stress MRI, stress echo, or further workup. So the question, what test should I order for my patient with chest pain? I think the most important thing, initially, you have to identify the clinical question. And then, centered on the patient, you choose your imaging modality, whether to go for coronary CT angio, for stress echo, stress CMR, invasive coronary angiography, or nuclear testing. So number one, identify the clinical question, and then think about patient-centered imaging. Important point in assessing the patient is the risk for cardiovascular disease. I mean, the pretest probability of coronary artery disease in the chest pain patient. So usually this is done on depending on the age, sex, and chest pain characteristic, and I think you know it in details even more than me. And accordingly, you will risk stratify your patient into a low-risk patient with expected adverse event of less than 1% per year, or intermediate risk, or high risk. So what is the cardiac CT? Before coming to, I will come later to this risk stratification. The cardiac CT is a routine CT, but requires some additives. For example, ECG gating. Why we need ECG gating in cardiac CT? Because we need to image or to scan at certain phase of the cardiac cycle. For example, we know that coronary arteries fills well during diastole. So for coronary CT angiography, usually we acquire our scan during diastole. On the other hand, for example, for CT TAVI protocol, the most important thing in the CT TAVI protocol is the assessment of the aortic annulus. And we know that the aortic annulus is maximum during systole. So we used to acquire our scan during systole. So depending on the question from the study, we decide the phase in the cardiac cycle. Another example, now we are using non-contrast cardiac CT for assessment of metallic valve for the function of the metallic valve. For example, if the question from the study is the metallic valve stuck or well functioning. In such a case, we used to acquire throughout all the cardiac phases, both systole and diastole, to show the opening and closure of the valve. Okay, are you following me?
Yes.
The other requirement for the CT, we need regular and controlled heart rate, and prefer the heart rate to be less than 65. This is very important and of paramount importance in coronary CT angiography to avoid the cardiac motion, because we know the coronary artery's diameter in millimeters. Usually the best cardiac CT, if the coronary artery diameter is more than 1.5 or 2 millimeter, which is usually the case. But the optimum image will be if the patient has regular and controlled relatively low heart rate, less than 65 beats per minute. The other thing needed in cardiac CT, the ability to hold breath. The patient will be able to hold his breath to avoid both respiratory and cardiac motion. The other requirements, some types or some varieties of cardiac CT needs IV contrast, and some will not need IV contrast, and we'll see this, inshallah, in the coming few slides. This is the cardiac CT. It is a routine CT machine. On your right hand, this is the patient within the CT machine. If we can see here, this is ECG monitoring. Will show the heart rate, and there is, to some extent, with only one lead. You can change the lead. Here is the patient lying in the table, scanning table, raising his both upper limbs above his head. Here is the technician or the nurse, most likely giving the patient the instruction before scanning. Here is the injector or the chaser, and we see it has two tubes here, one for contrast and one for saline. This will be connected to the patient, and this one reason why we need the patient to put his upper limbs above his head, so the connection will be easy and there will be no problem when injecting the contrast or the saline as flush. Okay.
Okay.
So for the patient selection for the cardiac CT, it is important to have or to know the guidelines and the appropriate use criteria, both international and local. If you have your own local guidelines or appropriate use criteria adopted locally, or you can use or follow the international one. The other thing, you have to do full patient review, starting from the patient accepting the procedure, because you are going to give contrast if you are going to do CT coronary angiography, and also you are subjecting the patient to radiation. So you have to explain the patient the procedure briefly and get his agreement to go. The other thing, make sure the patient is clinically fit to have the study, so he can lie flat, for example, for around 5 minutes. The scan itself is less than 1 minute, but including preparation, putting the patient in the table, acquiring the scan, and coming back to the patient may take around 5 minutes. Also, make sure the patient has no contraindication for your cardiac CT. For example, if you are going to give contrast, make sure the renal function is normal or near normal. If you are going to use beta blocker to more control the heart rate, or nitroglycerin to vasodilate the coronaries, make sure the patient has no contraindication for beta blocker or for nitrates. And usually remember that good studies begin with good patient selection guided by appropriate use criteria. A common concept in radiology and in cardiac CT, use the minimum required radiation. And there is a concept called ALARA concept, has to be applied. ALARA stands for, anyone knows ALARA stands for what?
No.
Alara.
ALARA concept.
Anybody?
Okay, ALARA stands for as low as reasonably achievable radiation. So to use the minimum required radiation, to do your diagnostic study with the minimum possible dose of radiation. And remember, always do no harm to your patient. Okay. So for the patient, I said we have to have regular heart rate and rhythm. Usually cardiac CT accuracy will degrade with increasing body mass index. And it is agreed that usually it is of good diagnostic accuracy if the body mass index is below 40. You have to have normal or near normal renal function. If you are using contrast, and the patient is able to hold his breath and to follow the breathing instructions, because after you finish your scan, you have to instruct your patient to breathe normally. So cannot keep hold breathing for a long time. Use of beta blocker and sublingual nitroglycerin, as I mentioned, and the ability to lift both arms above the shoulders. So before going into cardiac CT details, I want to review some cardiac anatomy. So I choose cardiac CT in axial plane or transverse plane. As we know, we have three main planes in cardiac imaging generally. We have axial or transverse. This is what is shown here. We have sagittal scanning from side to side, for example, from left to right or right to left. And we have coronal from anterior to posterior or from posterior to anterior. So here we are starting with axial slice higher up in the thoracic cavity, starting cardiac structure from above going down. So this is the ascending aorta. You are seeing my arrow here.
Yes.
This is the SVC. And the reason why we are seeing the SVC partially calcified or showing contrast and partially, this is due to flow effect, because we inject contrast through the venous system and it comes to SVC. It is from the upper limbs. So first it will go to SVC. Here, some contrast coming from my injection, some blood with contrast coming from my injection, and other blood without contrast. And here they are mixed. So this not to confuse anyone whether there is a filling defect or some abnormality in the SVC. You have seen this SVC?
Yes.
Okay.
Yes.
Yeah. As here is a main pulmonary artery bifurcating into right pulmonary artery and left pulmonary artery. Going down, there is the SVC, the aorta. Now the main pulmonary artery started to disappear. This is the right pulmonary artery, left pulmonary artery, and here one structure start to appear. This is the left atrial appendage. Going down, the left atrial appendage become more clear. The main pulmonary artery, aorta, and the left atrium appear in the field here. And this is one of the right pulmonary veins. And this is one of the left pulmonary veins. Okay, now I started to see the coronaries. Okay, this is the left atrium. This is the RVOT here. And this is the SVC. This is the aorta. So what is this vessel?
The phone.
What is
Left
this
main.
vessel? Zaru.
Left main.
It is left
Left main.
main. And what is this vessel?
Circ.
Why you said circ? So,
LAD. This is LAD.
Anterior.
This is LAD.
this is the aorta. This is the left coronary sinus. This is the left atrium, and this is SVC or part of the right atrium. This is most likely non-coronary cusp. This is the right coronary cusp, and this is the left coronary cusp. We agreed that this is the left main. This is the RVOT. Okay. What is this vessel with white arrow?
LAD.
The LAD.
LAD. You are right. And what is this one?
Circ.
And that one, diagonal,
This is the
is
circ.
the circ. Okay.
Diagonal.
So going down, we have the aorta. What is this vessel? Black arrow
Circ.
is the circ. Here is diagonal and LAD. And going down, what is this vessel?
To the right.
RCA.
RCA. Yeah.
Coronary artery.
Okay. And what is this structure appeared in the field of view now? Because you are going down.
The aorta.
Aortic
And the cusp.
valve.
Aortic valve. And what is this structure here? The LVOT. Okay. Is it clear?
Yeah.
So now we get 4 chambers in our field of view: the RV, RA, LA, and LV. What is this structure?
Yes. Yes. Very.
RCA. Going down, this is the RCA, and here is the posterolateral branch start to appear. Okay, RCA. This is posterolateral branch. What is this structure? This is a venous structure. This is the coronary sinus entering the right atrium. Okay, this is RCA. This is the LV. This is the RCA, BDA, posterolateral branch. Okay, RCA, BDA, posterolateral branch. This is the distal bifurcation of the RCA, and this is the BDA. So back to our cardiac CT. Usually our cardiac CT can be non-contrast enhanced. When we are talking about non-contrast enhanced, we are mainly talking about calcium score. Or contrast enhanced CT coronary angiography, we are talking about angiography. Some non-contrast CT, for example, if you are looking for aortic calcification, some contrast enhanced CT, for example, if we are looking for aortogram and other special types of cardiac CT. On your left hand, this CT, it is non-contrast. All structures have the same density. Here, the calcium is shown in the coronary arteries, here in the proximal circ, proximal LAD, and some calcium here in the pericardium. And just I want to mention one point. If we remember the case in the quiz with proximal LAD lesion, some people said calcified and some said non-calcified. As a general concept, in cardiac cath or invasive coronary angio, calcification will appear as radiolucent or black towards black. In chest X-ray and CT, calcification will appear as radio-opaque or towards white. So don't get confused with calcification in cardiac cath or invasive coronary angiography and calcification in cardiac CT. CT like X-ray. So the calcification will appear as radio-opaque. This is, I think, the reason why some people said calcified plaque for the proximal LAD lesion in the pre-test assessment. Here is calcium score. Here we see this reformatted coronary angiography of the RCA. It is normal. Here it appears as the C shape of the RCA. It is reformatted, not for, following the ideal anatomy, but we can see this is the LVOT, this is the LV, this is the aorta, and this is the right coronary sinus, and this is the RCA. So the white appearance here is for the contrast. So coronary CT angio is for contrast. And this is also one of the coronary arteries displayed in multiplanary format, taking in consideration the course of the vessel and forgetting the other anatomical structures. Is it clear?
Yes.
So
معلش يا دكتور عوض.
yes.
ممكن سؤال
Okay.
for the previous slide الاناتوميكال اورينتيشن. انا حقيقة عندي مشكلة في الاناتوميكال اورينتيشن بالنسبة للprevious slide. الستراكشرز دي اورتا و اي بي سي. ايوه دي الفوق ده الاورتا ده الاي بي سي. التحت ده
in this slide you are not having an ideal anatomy because in one slide we are showing all the course of the RCA. Here it is called reformatted image. Here the anatomy is not ideal. So usually in such reformatted images, if you got in the exam, they will give you some hint. We will see later how I will know this is the RCA and that is the LAD. But for this picture specifically, the anatomy is not ideal because the image is reformatted to show the whole course of the RCA. So I will not follow the anatomy, but it is clear here, this is the aorta, and this is the right coronary cusp, and this is the LVOT, and this is the LV appearing, because the contrast on the left side. Contrast, when we scan for coronary angiography, we time our scanning for the contrast to be on the left side. I mean, the arterial system, in the aorta, in the LV, in the left atria. Okay, so I expect the coronary arteries to take a reasonable amount of contrast and can be scanned and imaged easily. The other one, lower down, also, this is reformatted and deformed image. Only you rely on the coronary vessel. The other structures, forget about them, because this image was reformatted. It is
exactly. Awad, if you allow me, because you know, you have to know that, as Awad has stated clearly, that in CT they do reformatting. And the purpose of this reformatting is to depict the vessel across its entirety. So they stretch out the vessel completely for the sake of vessel analysis. And by doing that, they distorted the imaging, the anatomical planes. So you lost your tracks about where and which, okay? For that's the problem. So usually if it happens in the exam, they will give you a sign that this is what kind of vessel in particular. They won't give you these reformatted images and let you get lost like that, okay? That's it,
Yeah.
thank you.
Okay, thank you, Hatim. I hope it is clear now. So
Yes, thank you.
a few words about calcium score and coronary CT angio. The main difference between calcium score and CT coronary angio, calcium score is non-contrast study. CT coronary angiography is a contrast study. Calcium score done before giving contrast. This is very important. You cannot go back and do calcium score after giving contrast. Okay. The other thing, CT calcium score alone is indicated in asymptomatic intermediate risk patients for risk stratification. There is no place for coronary CT angio in asymptomatic patients. And I think you know the guidelines and the appropriate use criteria. As a fact, coronary CT angio is indicated in symptomatic patient with stable chest pain. So asymptomatic, no coronary CT angiography. Only you can do CT calcium score. For symptomatic patient with stable chest pain, you can do both calcium score and CT angio. But the most important point, CT angio is indicated. Symptomatic stable patient with stable chest pain. This is why, because there is no evidence of improved outcome with intervention in asymptomatic patients. So put at the back of your mind, no coronary CT angio for asymptomatic patient. This is the main message. The calcium score, if you have coronary artery calcification, this is specific for atherosclerosis. You can swear this is atherosclerosis, but it is not specific for obstructive coronary artery disease, regardless of the amount. So whatever the score you have, you cannot say confidently there is obstructive or non-obstructive coronary artery disease. You have to do the CT coronary angio. The most widely used score to quantify calcium in the coronary arteries is Egaston score, and this is established in 1990. It depends mainly on the density of the calcium and the volume of the calcium. The threshold is usually more than 1 cubic millimeter of calcium, and the density is more than 130 Hounsfield unit. Hounsfield unit is the unit used in CT to measure the density of the tissues. So if the density is more than 130 and the volume more than 1 cubic millimeter, this will be calculated or detected. And the most widely used score is Egaston score. Generally speaking, adequate visualization of the coronaries usually is better with overall calcium score of less than 300, but it depends on the distribution and the density. Sometimes you can find, for example, only calcium score of 200, but it is in one area and it is dense, so the diagnostic accuracy of that segment will be greatly affected by this dense calcium. But generally speaking, if the calcium score is less than 300, 400, you can still visualize the coronary tree very well. But the most important thing is the distribution among the segment and the density rather than the score value. Also, coronary artery calcium score of more than 1,000 is associated with drastic drop off in complete coronary tree visualization. And usually, if you have coronary artery calcium score in range of 1,000 and above, better to have an alternative method, because the accuracy of the CT angio will be affected very much. Also bear in your mind, non-calcified plaque is not detected by calcium score CT. because the calcium score CT, it is non-contrast and mainly for detection of calcium. You cannot comment on non-calcified plaque by doing calcium score CT scan. It is uncommon that patients with acute coronary syndrome would have 0 calcium score, but you can got it. Yeah, patient with acute coronary syndrome may got 0 calcium score. And also, acute coronary syndrome in the setting of 0 calcium score warrant aggressive intervention. On the other hand, high calcium score without acute coronary syndrome also warrants aggressive risk factor control. Usually there is a scale for ranging or scaling the calcium score. 0 is none, 1 to 99 considered as mild, 100 to 400 moderate, more than 400 severe. But the most important and precise scale depends on the age and gender cohort. And this is usually done in centile. Also, it depends on the ethnic group. Each ethnic group has its own percentile for age and gender match cohort. So if talking about calcium score of 400 in a 75 years old man, maybe less than 25% of the age gender match cohort. At the same time, 400 calcium score in a 20 years old female, maybe more than 95% percentile for age, gender, and match cohort. The precise scale depends on the ethnic group, the age, and the sex, and usually calculated in percentile. The degree of calcium correlates directly with the risk of adverse events and the likelihood of obstructive coronary artery disease. So if you have high calcium score, the probability to have obstructive coronary artery disease is high. And if you have low calcium score, the possibility or the probability to have an obstructive coronary artery disease is low. This is general speaking. So this CT for coronary artery calcium score, as we see, just go back to the anatomy quickly. This is the aortic root. Okay, this is the left atrium. This is the interatrial septum. This is the left. This is the non-coronary cusp. This is the left coronary cusp. This is the right coronary cusp. So this is the left main. There is a chunk of calcium, dense calcium in the left main. Calcium in CT appear white. Also, proximal LAD, there is dense calcification. So when doing this study and to calculate the calcium score, what I will do, I have the software, only I will circle the area and then highlight it. The software automatically will calculate the calcium and will give you the number. Is it clear? Go down to next slide. This also a slide showing a dense calcification of the left main bifurcation into LAD and SERC, and they are spotty calcification of the left anterior descending coronary artery. So if this patient, for example, referred for coronary CT angio to evaluate his coronaries, when I do this calcium score before giving the contrast, I can stop here. Why? Because I have a very dense calcium in the proximal LAD and in the distal left main and proximal SERC. This for sure is going to affect the diagnostic accuracy of my study. So I will stop here. There is dense calcification of the proximal left main, of the distal left main, proximal LAD, and proximal SERC, which may render the CT coronary angiography non-diagnostic. So I will go for other modality depending on the patient scenario. This is another example of coronary artery calcification. For example, the RCA, LAD, and SERC. Okay?
Okay.
For the CT coronary angiography, we can say generally it is sensitive, specific, accurate, with high negative predictive value. high negative predictive value means the CT is a good tool in our hand for ruling out coronary artery disease. The beauty of the cardiac CT coronary angio in ruling out coronary artery disease is why it is negative predictive value approaching 100%. Usually for CT coronary angiography, try to avoid high heart rates and extensive coronary calcification. This will negatively affect your study accuracy. Usually bear this in your mind. If your patient has high heart rate, for example, more than 65, 70, give him beta blocker, wait for a while, and then do your scan. If you did calcium score and there is high calcium score or dense calcification, especially in the proximal coronary arteries, stop and go for other modality. This is, I tried to show in one study the degree of coronary artery stenosis. For example, in this vessel distally, we can see there is a partially calcified plaque. This white dot is calcium. This black dot is non-calcified plaque. And in reality, this is a one plaque which is partially calcified or mixed plaque, but causing less than 25% diameter or luminal narrowing. So it is mild. If it is less than 25, it is mild. Mild to moderate, from 26 to 49, we can say mild to moderate. Moderate is around 50. Moderate around 50. If it is more than 50, approaching 70, we can say moderate to severe. And if it is more than 70 to 99%, it is severe. And if it is 100%, it is total occlusion. So this is the grading. Usually, the grading is done visual for the expert eyes, but you can do the diameter, the coronary artery diameter. For example, we will take this lesion. I want to quantify the stenosis here. I will go up or proximally until I reach the first healthy segment, for example here, and I measure the diameter, okay? Then I will go distally to get the first healthy segment, for example here, and I measure the diameter. I will get the average of diameter 1, diameter 2, and will be presumed the diameter for my segment. Then I will measure the diameter in my segment, and proportionally, I will calculate how much my segment is stenosed or diseased. You understand my point?
Yes.
Yeah. So usually, if you want to quantify exactly, go proximally for the first healthy segment, go distally for the first healthy segment, get the diameter here, diameter there, diameter 1, diameter 2, get the average diameter, take it as the diameter for the disease segment, calculate the diameter of your segment. This is usually done in short axis, not in the long axis. Usually do it in the short axis and get the narrowest diameter and calculate the percentage narrowing of that segment. Okay. Here as an example, we have CT, coronary angio. Why I said coronary angio? Because there is contrast in the aorta, contrast in the left atrium, contrast in the left atrial appendage, in the one of the left pulmonary veins, one of the right pulmonary veins. So this is the left atrium full of contrast, aorta full of contrast. Here is the left main. Because this is only one slice, this part of the left main most likely is normal and dropped out from this slice. But if I have seen this proximal LAD, this is non-calcified plaque, and it is become obvious or better seen when I have a background of contrast. For example, if this patient done calcium score only, I will not be able to identify this plaque. So this is severe proximal LAD lesion due to non-calcified plaque. Agree, ya shabab?
Yes.
Okay, this is another CT. This CT in sagittal plane from side to side, trying to taking the long axis or of the LAD. This is the LAD, and this is the anterior wall going down to the apex. Here are some dropout because this image is not reformatted. It is only taken as a slice. It is like a real slice. So what we notice here, there is what is called myocardial bridge. The proximal part of the LAD is crossing or going deep into the myocardium and then out of the myocardium. This segment, which is having this myocardial bridge, looks healthy. But because of the myocardial bridge, the diameter maybe looks smaller than the segment distal to it. For example, if we have seen this diameter, looks bigger than the diameter of this segment. But this segment is not narrowed because of being entrapped in the myocardium, and because of this myocardial bridge, it appears as if it is narrowed or diseased all over. And by the way, the segment of the coronary arteries that underwent myocardial bridging is less susceptible to atherosclerosis. One postulation is that it is because we know the epicardial fat surrounding the coronary arteries is found in the epicardial and in the grooves. So inside the myocardium, there is no visceral or epicardial fat. And this epicardial fat is thought it is injurious and causing inflammation and subsequent atherosclerosis in the coronary arteries. So it is unlikely to find atherosclerosis in a coronary artery segment which has myocardial bridging. This is important. But sometimes the effect or the depth of myocardial bridging, the length of the segment itself, may render the patient to be symptomatic with exertion. And there are a lot of debates and talks about the management of myocardial bridging for the coronary arteries with myocardial bridging. It depends mainly on the symptoms and especially with stress. Another role for the cardiac CT is the assessment of bypass grafts. And two important points in assessing the bypass graft is to check the patency of the graft and to assess the anastomosis site. These are the most important 2 points in doing cardiac CT for bypass graft, is to study the anastomosis region and to see the patency. It is patency rather than degree of stenosis. If it is high-grade stenosis or total occlusion, it is easy to be seen and confidently you can report it. But for example, mild, moderate, it is unlikely. You can say there is a patent graft, okay? Anastomosis, you can elaborate the anastomosis side very well and see if there is any narrowing or not. For example, this, as you see on your left hand, top left hand, this is a venous graft. Why it is a venous graft? Because it is from the aorta. You see, maybe radial graft. So it is very nice, patent, until the anastomosis. This area is, this is artifact, most likely reformat artifact. Here is the anastomosis with the main coronary artery. So here confidently I will say patent graft and with patent anastomosis and very good distal runoff. You agree? Also, to reveal the anatomy more obviously, we usually used to do volume rendering for the grafts to show the anatomical relation of the graft to other vessels or to other grafts. And also, if the graft is patent, you can very easily do volume rendering and show it in a 3D volume structure. For example, like this, these are 2 grafts here on your top right hand, this is one graft, this is another graft. So usually for grafts, patency and anastomosis, these are so important. You can do another processing. You can show, for example, this is lima, it is arterial, you can put it in red color. This is venous graft, it is venous. So you should want, for example, this venous graft, you put it in blue. You can change the color. This is the operator dependent. But you can show this lima is patent with good distal runoff. And this, what you see, looks like surgical clips. Is it okay?
Yes.
Yeah. Who can tell me, I want one to take this image on the left and right. Who can take on the left one, this one? Tell me what you are seeing in this image. Who can take it, please? Raise hand.
This is lima to LAD.
You are talking about right side or left hand?
Rima and lima.
You are talking about the volume rendering. Okay, this is okay, a graft study with volume rendering showing
lima to LAD and rima to looks like BDA.
Yeah, it is lima rima. You have to have full study or multiple slides to detect, yeah, or to follow the rima exactly. But this lima rima study. And what about the one on your left hand?
This is lima, I think.
It is a graft. Because of the limited slice, I cannot tell, but it is a graft. I don't see the proximal end. Yani, usually in imaging, describe what you are seeing. So here, you are seeing this myocardium. Am I right? This is the LV cavity.
Yes.
This is native coronary artery. This one is a native coronary artery. This one looks like anastomosis. Why? Because they are surgical clips outside. Looks like a graft. These surgical clips are outside the vessel. Agree? The other thing, the native coronary artery is severely diseased, both calcified and non-calcified plaque with severe disease in this segment. So this is most likely severe native coronary artery disease. A bypass graft, I cannot tell from this slide whether it is lima, venous, or radial. This is bypass graft with patent graft, patent anastomosis, and good distal runoff. Describe what you see. Agree with me?
Yes.
I think I can see some septal branches of this the native artery.
it is after that it will be يعني اجتهادات, maybe an artifact. Don't يعني commit yourself for, because even the image itself, it looks a bit noisier. You cannot say confidently this is a septal branch. And also the native coronary artery disease here is very diseased, it's severely diseased, both calcified and non-calcified. So this is severe native coronary artery disease, a graft with patent graft, patent anastomosis, good distal runoff. What about stents? Usually stents are rarely assessed by coronary CT angio after stent implantation, because if acutely, usually like stent thrombosis or stent restenosis, usually you go for invasive, or before the non-invasive, you will go to physiological study like nuclear stress test, but generally, if the stent is large, for example, with a diameter more than 4 millimeters, can be fairly evaluated with a good diagnostic accuracy. Or if the stent in the left main and diameter is more than 3 millimeters, And in 2 meta-analyses, they showed a sensitivity and specificity of 91%, and positive predictive value 68%, and negative predictive value of 98%. Bearing in mind the diameter of the stent, if not left main, to be more than 4, if left main, more than 3 millimeter. But still, there is a place and there is a role for cardiac CT to evaluate stents. Let us take this example. If we look for the top image, this one, it looks a relatively large stent. If we concentrate on the distal end of the stent, there is a radiolucency. This area is radiolucent more than the area distal to it and more than the area proximal to it. So I have to study this area very well, and this is concluded as minimal in stent restenosis. There is a flow in the artery distal to the stent. There is radiolucency in the distal stent, and this proven to be mild in stent restenosis. If we look to the example lower down, if we see the CT here, there is an area of severe stenosis, and mainly due to non-calcified plaque, and it is before the stent, I mean proximal to the stent, and involving the first early part of the stent. And this proved to be severe lesion and confirmed by invasive coronary angio on your left hand. So still there is a place for assessment of stent restenosis, in stent restenosis, and patency of the stent fracture, a lot of application for the CT. One of the important part, because in the CT you can delineate and evaluate the anatomy very well. And when you compare the CT, for example, with cardiac cath or invasive coronary angiography, cardiac catheterization has a limited anatomical information, and it is relatively invasive. On the other hand, in CT, you can do 3D anatomy, and it is fast, robust study, non-invasive, and relatively less expensive. So when assessing the anomalous origin of coronary arteries, CT is superior to invasive coronary angio or cardiac catheterization. Just pair this diagram in your mind. Usually, the pulmonary artery is anterior to the aorta. Pulmonary artery here is blue, aorta is red. This is the normal position. Pulmonary artery anterior to the aorta. If I have any anomalous vessel passing between the aorta and pulmonary artery, I mean in front of the aorta or behind the pulmonary artery, this course is called interarterial course or malignant course. On the other hand, all this diagram showing left main from RCA, anomalous left main from RCA. So here in the upper right, this is the left main from RCA, coursing between pulmonary and aorta, then dividing or bifurcating to LAD and SIR. So what do you think about this course?
Malignant course.
Yeah, malignant course, interarterial. This one here is the RCA. This is the left main coronary artery arising from the RCA and then coursing anterior to the pulmonary artery and then bifurcating to LAD and SIR. This course is anterior to pulmonary artery. So it is benign or malignant?
Benign.
Benign.
Benign. Benign because it is not interarterial. The malignant one is anterior to the aorta, posterior to the pulmonary artery, or interarterial, between the two arteries. This one, the left main retroaortic course, then bifurcating to LAD and SIR, and this course is the lower left. Is also benign. The lower right, this RCA giving left main It is retropulmonary or below the pulmonary artery, and it is also benign. Okay, you understand it? At the same time, I can got anomalous RCA from the left system, and it can go through malignant or benign course. It depends on the course. So we see some example. Who can tell me about the finding in this study?
Here, this is malignant course.
Go systematic, step by step.
This is
So-
cardiac CT.
I think I prefer one to take, because we have a lot of examples. Each one will have the chance to get. So who will take this one?
This is the cardiac CT malignant course.
It is coronary CT angio. It is using contrast. Okay,
Yes,
this is
yes.
coronary CT angio showing
Yeah, malignant course.
malignant course. What vessel you expect is this vessel?
I think this is a LAD.
LAD. Okay, it is a great effort and trial. So let us back to our anatomy. This is the aorta. All agree?
Yeah.
Yes.
This is the left atrium. Agree with me?
Yes.
The one which is white with contrast. The other one, this is the right atrium.
Atrium. Yes.
Agree?
Yes.
So this is the left atrium and this is the right atrium.
Huh.
All agree? And this is interatrial
Septum.
interatrial septum. So if this is the interatrial septum, what is this coronary sinus? What we call it?
Non-coronary sinus.
Non-coronary
Coronary sinus.
sinus. This is non-coronary sinus. So this one expected to be
Left
Left-
coronary
left-
sinus.
left coronary sinus, and this one expected to be
Right
Right.
coronary sinus.
right coronary sinus. Now we decide the right coronary sinus. So what expected this vessel?
RCA.
Okay.
RCA, because this RCA, this is the right atrium, and this is either the RVOT, yeah, and this is the right atrioventricular groove. This is the right atrioventricular groove. Okay, the arrow pointing to this vessel. What do you think?
Left coronary artery.
Let me.
Originate from the right coronary sinus.
It could be
But-
left main, it could be left
Yeah,
main,
LAD.
it could be,
LAD.
Yes.
okay,
Circ.
it could be
Could be
CERC,
CERC.
it could be left main, it could be LAD. I have to see the other left system coronaries. This is the LAD and this is the CERC. But here I have only one slice. So I will say this is a left coronary anomalous, left coronary from right coronary sinus. It is not arising from the RCA. So this is a left coronary artery arising. I'm talking about only this slice. Actually, this is a CERC because the LAD, there is no left main, the LAD coming from the left coronary sinus. The CERC arising from the right coronary sinus. And what about its course?
It is past posterior.
Coursing posterior. This is the vertebra. You see, this is the vertebra. The left atrium is the most posterior cardiac structure. Am I right?
Wow.
Yes.
So this CERC arising from the right coronary sinus, coursing posterior or retro-aortic.
Aorta.
Posterior to the aorta or posterior to the aorta?
Yes.
Posterior to aorta.
Posterior to the aorta. So this course, is it
Posterior to
malignant
the
or
aorta.
benign?
But become benign.
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 Benign, yeah. So this is CT coronary angio showing anomalous left coronary artery arising from right coronary sinus with a retroaortic Bengosen benign course. Okay. What about this? Who can take this one? This is volume rendering. and I put arrow and I labeled some structures. Who can take it? Hurry up, ya shabab, hurry up.
This is volume rendering CT.
Volume rendering CT.
Which is
Yes, you are
showing,
right. Excellent. Excellent. Showing?
Showing left anomalous of the left left vessel, which seems like the left main. Yes, it is a left main
It is
crossing
left main.
anterior
Here
to
you
the
can
pulmonary
confidently
artery.
say this is left main because it is bifurcating. Okay. And what about its course?
Anterior to pulmonary artery.
This is anterior to the pulmonary artery and
Anterior to the pulmonary artery, and extremely anterior. It is not interarterial. So this course is benign or malignant?
Benign.
this is benign.
Okay, agree. Benign course. Who can take this one? Hurry up, ya shabab.
Oh, that's it.
Describe what you are seeing.
This is contrast CT.
Coronary CT angio, okay.
Yes, now there is this is a left system originating
You mean this one, left system originating from
the right.
Right coronary cusp, not from the RCA. It is from the right coronary cusp and
Yes, and it is going between the aorta.
coursing between
The aorta, and I think this is the right outflow.
This is the RVOT, yeah. It is considered as interarterial course, and this course is
Benign.
Malignant.
no. If
Malignant course.
Benign.
it is malignant because it is coursing interarterial. This is anomalous left coronary artery arising from right coronary sinus, coursing between the aorta, and most likely this is part of the RVOT and pulmonary artery. So it is malignant course. What about this one?
This is cardiac CT. Sorry, CT coronaries, which is showing the RCA arising from the left coronary cusp.
Okay, RCA arising from left coronary cusp and coursing.
And it runs between the two vessels.
It is with interarterial course between aorta and pulmonary artery, and this course is
malignant.
Okay, one on the left, this is the RCA, it is called, and this is LAD, it is labeled. So LAD arising from RCA and malignant course. Agree?
Yes.
Okay, on the right hand image, this is the RCA, the left coronary artery arising from RCA and has malignant course. So aortogram or assessment of the aorta. Usually acute aortic syndromes, aortic dissection, intramural hematoma, and penetrating ulcer are assessed very well using the CT. For aortic dissection, the main feature in CT is to see the intimal flap that separates the false and true lumens. You can decide the extent of the dissection, for example, starting from ascending aorta or from arch or from descending thoracic aorta. So this is depending, then you can type the dissection. Also, for the intramural hematoma, when you use contrast or do aortogram, the hematoma will be very obvious, and we can see an example of that. So this is the case of volume rendering and showing the dissection flap. This is the dissection flap. Here also, this is cardiac CT showing the ascending aorta or the aortic root, even it is lower down. This is a dissection flap this is a dissection flap. We see we have two lumen. Even the density of contrast is different between the two lumens. So this is the true and this is the false lumen. This is the descending thoracic aorta. This is a dissection flap, and this is the true lumen, and this is the false lumen. Okay? Who can comment on the image, on this image? It is easy.
This is cardiac CT or aortogram.
Yeah. We'll start
which is
from our
showing
left hand, okay?
Which is showing the dissection flap. The left one, the right one, sorry, is the true lumen, and the left one, the larger one, is the false lumen.
Yeah. So this is aortic dissection, intimal flap. This is the true lumen, and this is the false lumen. This is in ascending aorta. So this is type A aortic dissection. The descending aorta, I cannot appreciate any dissection or intimal flap here. Okay, here going up, this is the aortic arch. So what you see here?
Dissection flap.
Dissection flap in the aortic arch. Here, dissection flap extending from the aortic arch to the descending aorta. Here, in the lower right image, you see these two arrowheads pointing to the intimal flap. So this is aortic dissection. Also in the descending thoracic aorta, there is intimal flap. So this is aortic dissection, and this is type A or B?
Type B. This is B.
Why? This is the ascending aorta.
This is type A.
Type A, you are right.
Extending up to the.
Yeah, you are right. Okay, who can comment on this image? This is a sagittal. I wrote it, this is a flap, this is the true lumen, this is the false lumen. So this is starting from the arch after the origin of left subclavian artery. So this is type B aortic dissection. The top image on my right hand, this is the ascending aorta. I cannot see a dissection flap. This is the descending thoracic aorta. I can appreciate a dissection flap with true and false lumen. So this is type B aortic dissection. Also here, going lower down, I cannot see the ascending aorta here, but I see the descending thoracic aorta. So this is descending thoracic aorta dissection. Yeah, is it clear?
Yeah.
Okay. So let us concentrate on this image of two parts in our left hand. If you see this blue arrow, you cannot delineate the structure. This is non-contrast CT. Non-contrast CT. You cannot delineate the structure very well. The same patient, after giving the contrast, so we can appreciate the aorta very well, the ascending aorta and descending aorta. And we can, what is this around the aorta? What do you think this?
Hematoma.
This is intramural
hematoma.
Intramural hematoma. And when we do sagittal reformatting, so we can appreciate this intramural hematoma extending, extending along the aorta. So don't forget the other two components of acute aortic syndrome, intramural hematoma and penetrating ulcer. They are well seen in cardiac CT. Who can comment on this image?
Volume rendering CT.
Yeah, volume rendering CT, okay.
Which is showing coarctation of the aorta.
Showing coarctation of the aorta distal to the left subclavian artery with post-stenotic dilatation.
Dilatation, yes.
Yeah, other important thing, I have to look for collaterals. We can see the internal mammary arteries very well. It doesn't seem that they are well dilated and no intercostal vessels. sometimes you will see very huge collaterals with coarctation of the aorta. So bear in your mind to look for the collaterals if you have seen a patient with coarctation. Okay. Pericardium. Pericardium is an important part of the cardiac assessment by cardiac CT. Normal myocardium, we know it is less than 2 millimeter. Any pericardium.
Sorry, Awad, I think we have exceeded the time for, I don't know if they are still, because that will be probably too much. We are 1.5 hours already.
Okay.
So
okay,
it
I
will
will
probably be
go.
too much if this will take more than 5 minutes.
Okay, I will go quickly. I will go quickly. So in pericardium, usually pericardial thickness is less than 2 millimeter. If it is more than 4 millimeter, we can say it is thick pericardium. Pericardium calcification and thickening are not diagnostic for constrictive pericarditis. For constrictive pericarditis, we need to show physiology of constriction. This CT showed pericardial effusion. This one showed pericardial calcification. It is white. This white one is pericardial calcification. And this one showed thickened pericardium, not calcified, thickened pericardium. So this is pericardial effusion. This is pericardial calcification. And this is pericardial thickening. This one showed pericardial calcification. So for the valve, CT has a low role in assessing the valve, but you can use CT angio as risk stratification for valve surgery to assess for the coronaries in low to intermediate risk patients. This is only use. This is an example of CT for a mechanical valve. This one showing a good closure of the valve. This one showed a stuck leaflet, one opening and one closed. Okay, this is aortic, good diastolic closure. This is aortic, partial systolic opening. So this is partially stuck valve. This is aortic in diastole, very well closure. This is systole, very well opening. So the lower one are well functioning. This one well functioning. This partially stuck. Okay. Additional application, for example, myocardial disease, masses, congenital heart disease, TAVI, and other valve intervention, assessment of pulmonary veins before EP study, aortic calcification before cardiac surgery. So for the other application, for example, this is CT showing LV apical aneurysm. As we can appreciate, this LV apex is thinned out and there is a thrombus here. This is LV apical aneurysm with calcification, indicating an old myocardial infarction and apical aneurysm. This is LV pseudoaneurysm with myocardial rupture and with a thrombus inside it. And this is also another pseudoaneurysm, LV pseudoaneurysm. This is VSD. This is interventricular septum. This is VSD. And this is also VSD. This looks like 4-chamber view. This is an ASD. This is the left atrium. This is the right atrium. Also here showing the both atria with large ASD secundum here. What do you think about this mass? It's frequently seen.
Myxoma.
Looks like, yeah, atrial myxoma. So it is attached to interatrial septum with a stalk, and this is left atrial myxoma. Yeah. The advantage of CT, I mentioned most of it. The limitations are mainly artifacts. We can go through some artifacts. This is streaking artifact, usually from metal, from electronic devices or leads. For example, from the lead, you can go streaking, looks like shining out artifacts. Also, there is beam hardening, usually seen behind the metal or behind the dense calcium. This black artifact or the area of signal void behind dense structures like metal or calcium, it is called beam hardening. Dense calcification or high calcium score, for example, this patient underwent coronary CT angio. You cannot comment on this segment because of the dense calcification. When this patient underwent coronary angio, it showed what looks like mild to moderate LAD disease. So with this dense calcium, you cannot confidently comment on that segment. The stent, most important is stent diameter. We mentioned that 3 millimeter for left main, 4 millimeter for other vessels, and the strut thickness. If the thickness is high, the diagnosis accuracy will be low. For example, with 1.1 millimeter strut, it is difficult to comment on this segment. But with thin strut, 0.08 millimeter, you can comment on this segment. Opacity will make the cardiac CT noisy. Noisy means you cannot differentiate between the structure borders and you cannot eliminate so the image quality will be bad. This is high heart rate will cause motion artifact, cardiac motion artifacts. Also, not holding breath will cause motion artifact, but this one affecting only the heart. This is due to high heart rate causing motion artifact in the heart. So if you are interested, I have some slides to show. Hatim? Hatim? Can we go through some slices?
Wallahi, Awad, I think we are way behind actually. What time we have actually exceeded the time. So
many interesting slices. We can review some cases for general cardiology. So I have 5 short cases. Who can take? 43 female with atypical chest pain, diabetic, overweight, body mass index 29, ECG normal. What is the next step? Cardiac CT, cardiac cath, stress nuclear study, treadmill stress test. 43 female, atypical chest pain, body mass index 29, ECG normal.
Cardiac CT.
Cardiac CT. Okay.
Treadmill stress test.
Treadmill stress test. Yeah, I think treadmill stress test. She is relatively low risk patient with atypical chest pain and normal ECG, and she can exercise. Treadmill stress test is the best option. The patient underwent exercise stress test that was negative. 2 months later, she came with the chest pain that is more frequent than before. Next test is cardiac CT, cath, repeat nuclear stress test, or treadmill stress test. The same patient had treadmill stress test negative. 2 months later, she came with chest pain again.
Cardiac CT.
Cardiac CT. And this is one of the appropriate use of coronary CT angio, new or worsening symptoms after stress test. Okay? Case number 2, 63 male, not known to have risk factor for coronary artery disease, presented with acute central chest pain for 1 hour. ECG showed STT change. Troponin was high. So the most appropriate test, cardiac CT, cath, stress, cardiac MRI.
Yes.
Yeah, high risk patient with typical symptoms, ECG change, positive troponin. So cardiac cath.
Yes.
35 female, pregnant, complain of increasing shortness of breath with exertion. Cardiac auscultation revealed high first heart sound and diastolic rumble. What is the best diagnostic test? Cardiac CT, cardiac cath, SPECT, echo, none of the above.
Echo.
Okay, echo, this is MS. 75 male, known to have diabetes, hypertension, ischemic heart disease with moderate LAD and RCA lesions on prior cardiac cath 5 years ago. This patient, 75, with multiple risk factors and known to have moderate LAD and RCA disease 5 years ago. Presented with transient left shoulder pain that improved spontaneously. ECG and cardiac markers are negative. What is the most appropriate next test? Cardiac CT, cardiac cath, SPECT stress test, treadmill stress test, or echo?
SPECT
Treadmill
stress test.
stress.
SPECT
This
stress test.
patient, high-risk patient, known to have coronary artery disease, now atypical chest pain, ECG, no ECG
Invasive.
change, and negative enzymes. So I better to have
Cardiac
physiological
CT.
study. SPECT stress
Huh?
test.
Spec-
SPECT, yeah, you have to have an evidence of ischemia before going invasively. Last case, 31 male, no past medical history, presented with chest pain for 3 hours. He denies alcohol and drug abuse. ECG showed ST segment elevation in the inferior leads.
Yes.
What would be the most appropriate? CAT. Okay. He underwent emergency CAT, showed normal coronaries. His subsequent cardiac markers showed troponin of 13 microgram. What is the next diagnostic step?
CT.
Echo, cardiac CT, cardiac MRI, SPECT, stress test, no test required. Why you said CT?
Maybe the
This
system.
patient has normal coronaries.
No test required.
Cardiac MRI.
Cardiac MRI. Good. Why you said cardiac MRI?
To exclude myocarditis.
This patient has normal coronaries and elevated troponin, so looks for other types of myocardial injuries other than myocardial ischemia. So cardiac MRI is the best option. Thank you very much.
شكرا جزيلا.
Thank you so much,
you.
Awad. I think we all enjoyed this, and I don't think if you have like 1 or 2 questions for Awad, I'm still okay with that. Lakin, we are actually out of our time. So if you have any 1 or 2 questions, I'm okay. Do you?
We want to answer the pre-test question only to see the answers.
خلاص
you
ممكن
want
نرجع
to-
للسبيك question يا عوض.
Okay, I will go it. I will go through it quickly, please. Okay.
The SPECT.
معلش حاتم, can you share me?
Okay. You
حاتم.
are still the host, actually.
Okay. It is not appearing.
But
Okay,
here,
1 minute, 1 minute.
it's the
Now-
75-year-old with prior, I think, revascularization and came with chest pain, which sound atypical, and they want to do non-invasive testing for provocable ischemia. And the choices were treadmill testing, echo, SPECT, or cardiac CT. I think there were the options like that.
No, Hatim, I can go through the, because I cannot open the slide. The negative predictive value for coronary CT angiography is around 99%. Okay.
Yeah.
The second question.
The question is, he is asking about the last question you have showed about the SPECT, right, Doctor?
No,
لا pre-test هو.
the pre-test.
The pre-test. Okay.
The pre-test. The second
Okay.
question, the 50 years old man, asymptomatic, and he asked to do a cardiac CT, so you will do for him coronary calcium score only. Coronary calcium score only, he is asymptomatic. The third question, 55, obese male, history of diabetes.
Can I done?
Okay.
Okay.
Are you talking to me? I didn't hear you well.
Yeah, here are the questions if you wish to see.
Okay.
Hatim,
Yes,
you can open the second one because I'm not able to
the
share the
second
screen.
one.
The second one with the
Here is
answer.
the second one. Okay.
Okay, share the screen.
Yes, خلاص, it's there here.
Okay, it is with answer. So the third question now, we already answered question 1 and question 2. The third question, 55, obese male, history of type 2 diabetes and hypertension, present to the ER with chest pain, and his contrast enhanced CT coronary angio showed the images. Here is a proximal LAD, severe disease due to non-calcified blood. Because this is radiolucent blood, this is non-calcified, the lesion is severe, location is proximal LAD. Okay?
Yes.
Okay.
Question number 4. This is the patient with aortic dissection. We've shown 2 images, one coronal and one axial. In the coronal one, we can appreciate intimal flap arising from aortic root to the origin of the brachiocephalic trunk, extending to the branches. And in the other image, we can see intimal flap in the ascending aorta and descending aorta. So this is aortic dissection type A. The last question, the 50 years old obese female with history of hypertension, she presented to ER with chest pain, and she had contrast enhanced CT chest, and the images showed one on the top left. This is the pulmonary, main pulmonary artery with bifurcation into right pulmonary artery and left pulmonary artery, and we can appreciate a filling defect in the right and left pulmonary arteries. In the other axial image, the RV is dilated. The RV is dilated. The septum is bowing towards the left side. So this is major pulmonary embolism. Major pulmonary embolism. So treatment is thrombolytic therapy. Okay, I hope I present something.
Thank you so much, Awad. Wallahi, we can't thank you enough, Awad. That's great. And that's a full review of the cardiac CT, I think. Well, thank you
I
for
tried
all
to
of you.
compress it, but it is a huge topic, you know.
Yeah.
It's very difficult to cover the whole.
لا والله لا جد you have actually walked us through all the applications and utility of cardiac CT, and I think that's an overview, and this is cover all the basics, I think, of any cardiologist should know about cardiac CT. Okay, so well done, Awad. Thank you all of you.
Thank you all.
Hopefully we are going to meet next week. Thank you, everybody. Thank you. Thanks a lot.
Good luck for all. Good luck.
Thank you.
Good luck.
Thank you.
جزاك الله الف خير يا دكتور عوض.
الله يبارك فيكم، بالتوفيق يا شباب.
ان شاء الله. الله يسلمك.
شكرا لك دعواتك.
الله يبارك فيكم، بالتوفيق ان شاء الله. الله يسلمكم. الله يسلمك.